She just can't organize herself. He doesn't want to study. Plain, simple, lazy. What might seem like a habit could be more than that. Growing up with attention deficit hyper disorder, ADHD, comes with its set of challenges and rewards. Learning how to focus on these rewards while managing the limitations can be the game changer. As we begin today's talk by Dr. Monalisa Palit, Senior Consultant, Clinical Psychologist, VIMHANS, on the much misunderstood condition of ADHD, we have one request, besides, of course, asking you to keep your phones on silent. Let us put aside our judgments and listen in with an open mind to enable better understanding and support to our own self and those around and close to us. Dr. Monalisa Palit, a Ph.D. from Sydney, is a licensed practitioner with a specialization in child and adolescent mental health issues and developmental disabilities with over 20 years of experience. She is currently engaged as a senior consultant with VIMHANS Hospital, New Delhi. In the course of her career, she has come into contact with a diverse population whose learning and social emotional functioning levels covered a wide spectrum. She has provided therapy for individuals and families on clinical and non-clinical issues, including but not limited to psychiatric conditions like depression, anxiety, conduct problems, and personality issues. She has an eclectic approach to psychotherapy, which allows her to fit each client's needs uniquely. Furthermore, she conducts workshops for schools, NGOs, and corporates on a wide range of topics, varying from awareness building to clinical training. She is currently also heading a structured and well-regulated training program for school counselors in collaboration with ICMR, HHSC, and VIMHANS. The program comprises a rigorous training curriculum and hands-on training in assessments and counseling skills, aiming to enhance professional expertise, help close the treatment gap, and strengthen preventive, promotive, and rehabilitation services. Our partner for this talk is the Mind Diaries, the first of its kind magazine in India on mental health and well-being. The magazine, which has been running for close to a year, aims to create awareness towards mental health and normalize seeking expert help. Besides first-person stories and accounts of fighting back, there are expert columns, inspirational stories, and more. Before we hand over to our expert, we request you to please keep your questions ready for our question and answer slot scheduled for the end of the session. Over to Dr. Palit.
Good afternoon, everyone. Thanks to Internet and Google, we all have some basic knowledge on lot of things nowadays. So in that context, before I start today's presentation, I would like it to be interactive as much as possible. And when we talk about ADHD or attention deficit hyperactive disorder, anyone would like to say something that they have understood what it means? Anybody wants to open the discussion? Yes, please.
People who cannot concentrate for long periods of time, they find it difficult to focus.
Okay.
That's all I know about it.
Alright. Anything else? Yes,
The
please.
attention span, the retention of the things is so difficult, and sit at one place and focusing on things is so difficult for them. Because I work as a mental health counselor specifically for poor communities, and now the the cases are coming who are neurodivergent poor, and more of them are ADHD. And
You're working with specific school setting?
No, I'm a mental health counselor with Keshav Suri Foundation.
Alright.
So to learn about it, I have come here.
Alright. Anyone else? Okay. Let's start with what is not ADHD, the myths that we have. ADHD isn't a real medical disorder, it is a modern farce created by drug companies. Why I put it up this as a myth? Because in our clinic, when in my clinic over the years, what I've seen, parents generally, I mean, understandably, they have very reluctance with, especially with the psychiatric medications, worrying more of the side effects rather than the benefits. And lot of people has made this comment that, I mean, it's maybe it is because of the drugs that you want to sell from the drugs company, because it is actually coming from the diagnostic categories coming from US, and they do have that, negative connotations attached to it. So let's see what it means. Any idea? Anybody wants to make a comment before I do? Well, yes, please.
Is this? It's a neurodevelopmental condition that involves basically three kinds of symptoms, which is inattention, hyperactivity, and impulse control. And I am a neuroscience graduate, and I have ADHD myself. And I am here because the rewiring the brain is something that I really don't know much about, which is great. So I'm looking forward to talk about that.
Yeah, it is, when we say it's a neurodevelopmental problem, I'll come in detail. It does have a biological basis. What I understood from the parents interacting at VIMHANS is what we don't have, which is not specific to ADHD, but most of the psychiatric conditions, is that we do not have biological validity, which basically means that though we understand the biological basis of ADHD or any other medical conditions now, whether it's depression, anxiety, or any of the developmental disabilities like autism or ADHD, we know, but it is coming, understanding is coming from the, retrospectively from the neuroimaging studies. So it's like, what it means is that we know what is the an individuals with non-ADHD, and you're comparing the brain imaging with the ADHD individuals, and we are seeing the differences. When we talk about biological validity, like say if you have a cancer or diabetes, we have a blood test, we have other objective diagnostic tests. For mental health conditions, including ADHD, we do not have yet the diagnostic blood test or neuroimaging, any of these, for us to specify this is the criteria, this is the range you are crossing, then that means you have depression or ADHD. That is the gray area that we all mental health professionals are operating at. So that is the difference between where there is a lack of understanding comes into it. We do not have any objective diagnostic tests also. What we have is a rating scales where we have to tease it out, the conditions, based on our own clinical experiences and the way the responses are coming from the individual or the parents of the child. So these are the, because of the subjectivity involved in it, that's why you can, a lot of people feel that it is not a condition, especially, it's a recent one of the diagnosis, 2 generations ago, this kind of did not exist, or at least did not have a nomenclature for it. So that is one of the reasons because of this misdiagnosis. ADHD is the result of bad parenting. Any comment on this anyone would like to make? When we say ADHD is a neurodevelopmental disorder, which means there is something at a brain level which is not in our control. That means environmental factors are not causing it. So ADHD is not caused by bad parenting. But yes, as a parent, we need to understand how to handle the child with an ADHD so that we can manage it better and it doesn't have any long-term implications. I'll come to this, I'll elaborate on this point in my presentation today a little later once we've described it. But for now, it's not a bad cause, is not a bad parenting, but yes, not bad parenting, but more of a mismanaged, in case we parents may not be able to understand, or then it can lead to more difficulties for the child. Affects boys only? No, the ratio might be more boys to girl, but it affects both genders. A kid who can play video games for hours could possibly have ADHD. That means, what it means is that if a child can concentrate for 1 hour on a video game, why can't he concentrate for half an hour in reading, writing? That's the question. I'll hold on this question in my presentation. Hold on to this thought. Children with ADHD eventually outgrow their condition. If diagnosed at an appropriate age and managed well, the symptoms is not as significant and it does not impact day-to-day life. So it's not a question of whether we outgrow it. 50%, various research comes on an average about 40 to 50% of the children diagnosed with ADHD go into the adulthood as well. The manifestation of the symptoms at a behavioral level obviously differs between child and adult. I'll discuss it in detail today as well. And if it is managed well, it does not impact day-to-day life. So you can say, yes, may not be as apparent the symptoms at a later age. That's at least the similar symptoms, especially hyperactivity and impulsivity in the adulthood. Children who take ADHD medications are more likely to abuse drugs. Any comment on that? It is not the medications. Multiple research, meta-analysis, meta-research are there to say ADHD drugs does not lead to overuse of drugs, but inherent condition of the condition itself in the ADHD predisposes a person under certain circumstances to be drug dependence. That's a comorbid condition, not because the person is taking ADHD drugs to manage the symptoms. People who have ADHD are stupid and lazy. I'll leave this question for the later to address it. Now that we know what it is not, please don't hesitate to stop me and ask the question. If any particular slide you have questions, I'll answer it and then there, and as well as I'll take it on at the later stage.
These misconceptions are many more.
Pardon?
These 7 misconceptions.
No, I just put up the major ones. If you have any questions, I'll answer it. Let me go through what it is. There are a few more. I've just made the major ones which is coming up. If you have any question, I'll answer it. I'll just go on to the attention deficit hyperactive disorder is a neurological condition that involves problem with inattention, hyperactivity, impulsivity that are inconsistent with the age of the child. It's persistent pattern affecting day-to-day life across multiple situations. What it means is when we say it's a neurodevelopmental problem, that means it is at a brain level. It is not in our voluntary control. If it is not in our voluntary control, it has to be pervasive in nature. It cannot be situation. Like I can have attentional issues only at home but not in school. Or it has to be across multiple situations, at least 2 to 3 situations. And it is inconsistent with the age of the child. Now to bring back to the question, when we say inattentive or hyperactive child, inconsistent with the age of the child, first, before we say the child is inattentive or hyperactive, we need to know what is the normative range for attention of a 2-year-old child or a 5-year-old child or a 20 or a 14-year-old child. The normative range we need to know before we can say that the child is inattentive, which is non-normative. Do you have any idea what is the average attention span at a different age group? You'll be surprised when I put up the slide. For a job that you don't want to do. So first of all, what it means, before you term a child as inattentive, labeling a child, please be sure what is the normative. A 2-year-old or a 5-year-old or a nursery-going child, if they don't want to sit for more than 5 or 10 minutes to do the drawing, the sleeping line or a standing line, that needs to be addressed at a discipline level, not because the child is inattentive or hyperactive. First, we need to know what is normative before we know that, yes, it is a problem. I have some more interesting data. Do you know the last 15 years, on an average, the human's attention span has decreased, which is less than the goldfish? On an average? For the things that we are not interested in, we scroll through our phone, but we scan. We don't read 90% of the text that we are scrolling in. So if I put these two information out to you, that forms the basics before we label the child, or we use these terms. These are medical terms, but we use it so casually. The child is hyperactive. Oh my God, he's so inattentive. What should I do? He's becoming impulsive. Please use it with little respect. These are clinical terms, not to be used so casually, especially in the context of children. Prevalence rate, 2 to 5%. In India, it's 8%, which means more than 90% of the kids are not ADHD. So every second child which you see as a nursery or a KG or a grade 1, they are not ADHD just because they are naughty or hyperactive or inattentive. That needs to be built up, the attention span, through discipline. The ratio of girl is to boy 6:1 across studies, more or less. Let's understand, now that we know what it is, let's understand each of these behavioral levels that we understand hyperactivity and impulsivity symptoms, how it manifests in behavioral wise. At behavioral level, how it manifests. Fidgeting and wiggling, running or jumping around, getting up or leaving the seat when supposed to remain seated, excessive talkativeness and noisiness, interrupting others, blurring out answers, difficulty in waiting or taking turns. Let me give you a scenario. In a class, the teacher is coming and going, a period is got over, and the children at the back bench in a class of 30, they start talking to each other. They are get up from the seat and everything. Well, this thing, is it a normal behavior or not? And if the teacher has to say, come on, get on this thing. Or the teacher turns into the writing to the blackboard and the backbenchers start talking. Is it a inattentive child or an hyperactive child? Why not? I was doing a one program with the teachers in a high-end, one of the top private schools in Delhi. They were a class of teachers of 15 teachers in a group. I was taking a class. Some teachers asked me a question. I was answering that, and I could see the two other teachers talking there between themselves. And I had to point it out that if you're doing it in a class of 15 with an adults, if a class of 30 with any of the grades, even if the nursery or the grade 12 or the grade 8 gets up and talks, why do you have to label the child like that? So when we talk about getting up, leaving the seat, supposed to remain seated, excessive, talkative and noisiness, it has to be evaluated in the context. It's not arbitrary, all-pervasive statements. These are the general behavioral manifestation of an inattentive individual with ADHD. Leaves activities, appear to not listen when spoken to, distracted by the environment, difficulty following a set of long instructions, forgets things, objects, activities, losing things necessary for an activity, lack of focus on details of a task, reluctant to engage in tasks that require sustained mental effort, difficulty to plan ahead. Hold on to this thought, I'll come back into this. Inattention, when we talk about, it is part of our executive functions, higher order executive functions. The way that is the rational part of our brain, the prefrontal cortex of the brain that we talk about, which is involved for organization, working memory, cognitive flexibility, attention. All these are part of higher order executive functions. Inattention needs to be understood. Each of these symptoms needs to be understood in the context of executive functions. What are these executive functions? I'll take up these are the other associated characteristics of children or individuals with ADHD: emotional regulation and social skills. Let's take up one by one. These are the executive functions: cognitive flexibility, working memory, inhibitory control, task initiation, planning and prioritizing, self-regulation. When we put it up into this context, inattention symptoms has to be evaluated in the context of executive functions. What does it mean? When we talk about inattention, it is not inattention, but more often attention dysregulation, which means the child might be able to hold attention on an area of interest for a longer time, but not able to shift their attention to the other mundane task or the regular task that is assigned to. So inattention is defined in the context of not so much of inattention, but more of an attention dysregulation. When we say attention dysregulation, it becomes in the context of cognitive flexibility, or rather cognitive inflexibility. That means if you are engaged in one task which is of interest to them, say a video game, and for some a person is calling by name, or you have to get up and switch it off the game and will go into somewhere else, they have difficulty to shift. They stop it there, one more time, five more minutes, mama, and it continues. So they are switching from one activity to another. They have difficulties. Yes?
But it should take some effort, right?
Yes, that's what I said. They have difficulties.
No,
it's not.
But any other supernormal, right?
Yeah.
It should take that effort to switch, right?
Yeah, it takes for us, all of us, to shift from one activity to another. But when we talk about this cognitive disability, what we're talking about, more than an average person.
Right.
Right? But my question is to you, if I look into it, is it a problem always? Yes, in some context it is. Because when you have to do, like, you're playing game, you have to sit down to studies. Especially in school, day-to-day life, it might make a difference. I mean, it is a problem for the parents to say that you're not able to, everything you have to remind, get up and do it, and then you have to come and, give a physical prompt or stop it where there is, all these, difficulties that the parents get it. But in other contexts, this same inattentiveness, which is the other name for or attention dysregulation or focus, is called hyperfocus. When we talk about hyperfocus in this context, which is arising the other side of the coin of inattentiveness or attention dysregulation, is hyperfocus, that you're focused on something which you are interested and you are able to do that. In certain cases, in situations, especially in adult, probably it is a boon rather than a problem. For certain work, for creative work, once you are in it, you want to complete it. When you are writing something, you probably don't want to be disturbed. So the other side of the yes.
I'd just like to take an example of an aunt of mine. She is actually 75 years old and was recently diagnosed by a relative who happens to be a school counselor. And why I'm mentioning this is that this aunt of mine, she's 75, she's a very successful realtor in the US. So every time that we've met with her, she loses her trail, her conversations go on, and in general, we find that she's different. So we would find every time she would start talking about something, or she would be gardening in the yard, or she would be painting or cooking, her husband would have to raise his voice to call her or to deflect her attention. Aside from all of this, she's actually a very successful realtor, as I said, which entails a lot of documentation, a lot of conversation, a lot of client-based interaction. So she's actually doing really well. She's thriving without any interventions.
What I wanted to highlight here is what we look at symptom at certain level. In certain situation, in everyday regularity of the work that way when the kids are growing up and everything, it might become, it's maybe a problem or it is a problem. But the same problem can be turned into a strength as well, with a proper management and with a proper career choice or focus. So the other side of the coin of inattentiveness is hyperfocus. So when we talk about these symptoms, appear not to listen to when spoken to, or difficulty in following a set of instructions, forgetting, if you're preoccupied with certain activities, certain things, some of these can be understood also in that context. Working memory, cognitive flexibility, the other executive function skills, has a hard time sensing the passage of time, difficulty with future planning, focuses on small details, failing to meet deadlines. These are also examples of people who are hyper-focused on certain activity for that duration, which might be beneficial for that period to get a job done. So the symptoms need to be understood in the context. Emotional dysregulation. When we talk about impulsivity, act first, think later. They might say sorry, but they jump into the activity, and then they realize, because they have not thought through the activity, what are the pros and cons of that behavior or the activity it can be. So basically, quick to anger, meltdowns, low frustration tolerance, struggles with not getting their way or letting things go, becomes explosive when told to get off screens or video games, has difficulty working with others, argumentative, can become physically aggressive, can be impulsive, appears not to learn from the past experiences, has a hard time recalling how they performed the task in the past. Some of these needs to be understood in the context of the third aspect, which is the social skill. Social cognition. Some of these children with ADHD or the adults with ADHD, they have difficulty in perspective taking. That means they are more inward focusing. That's why they become hyper-focused. But at the same time, that's why lot of times they fail to understand other person's perspective. That is, we call social cognition. It plays an important role in initiating and maintaining interpersonal relationships. So when we say that ADHD children, they make friends but they cannot sustain friendship, because any of these sustaining friendship or to interact, when we talk about meltdown, becomes explosive when told to get off, inflexible, prone to quick to anger and meltdowns, that needs to be understood in the context that they may not be able to take that perspective taking. What we call understanding others' point of view at that point of time. So if you're not able to understand what the other person is saying, why the other person is saying, whether it's a parent or a friend or a teacher, right? So you would be reacting from your perspective. And if your perspective, I want to do this and I don't want to do this thing, so then you have these sort of behavioral manifestation of your emotions. So what we call it anger outburst, low frustration tolerance, and all this is coming from that perspective. Yes?
So I'd like to share.
Yes.
So I have a child who, kind of slipped through the system. He was in one of the most inclusive schools in Delhi, and it should have been spotted, because some of these are so obvious, and it's like you're actually talking about my kid. So he basically slipped through the system all the way till grade 11, and finally at the end of grade 11 IB, we we were recommended at that time, the school that he was in sent us to Dr. Shelja, and we got a comprehensive 28 page report, and and then suddenly a lot of things fell into place. Now in grade 9, he did something so stupid, what you say, appears to do things without thinking about outcomes or consequences. We had to pull him out of that school. We had to kind of shift his school, almost homeschool him. So he basically for 2 years really spoiled his whole thing. And then at the end of grade 11, he was diagnosed with this, and a lot of things fell into place. But the point is that going forward, very often, now he's currently in a US university, he gets a lot of accommodations for his academics, and he's brilliant, he's made the dean's list and whatever. But a lot of times he just, doesn't appear to learn from the past experience. So, he'll kind of walk that fine line where, if and as a parent, I'm just constantly worrying because I don't know what to do. I'm like, this has consequences. If you do this, you're going to get into big trouble, and you've already got into trouble. So, can you just be mindful?
I'll tell you maybe one of the reasons that he doesn't learn from past experiences. Children with ADHD have poor episodic memory. What it means is, any episode that has happened before, like the incidents that you're talking about, the past experiences,
it was so traumatic.
They would pick up on the negative or something. They do not remember, or the poor episodic memory, which means as a child you have to tell them that, do you remember this is what you did, and this is what you positive, and this is how you handled it. So there needs to be remembered to make it internalize. It doesn't come naturally. It's because of the poor episodic memory.
But then my question to you is then the moral, their understanding of moral consequences.
It's not a question of moral understanding, moral consequences. It's just that they don't remember that what was the last incident or the situation, that what I did or what I did not do. It's not a question of moral context at all. It's nothing to do with morality. They know what they should not be. That's why they say, I'm sorry. Right? Because they do understand that they should not be doing it. But that is what it is, that because they have a poor episodic memory, especially for the positive ones. And they need to be connected as a child, to be told, like, do you remember what you did last time? And this is what you see.
He's an adult now.
Yeah, that is the thing. But the question is, that is the reason. One of the reasons could be because of that. So that's why I said it appears not to learn from the past experiences because of that. That's why I put it up, that example, or this behavior.
If I may add something, don't make it feel guilty. Human beings are not machines. You have to empower the person or the child to decide what you want to aim without being influenced.
Yes,
We are not machines, we are all different. That is it. We don't need to be fit into acknowledge he as a human being and an independent person.
So these two needs to be understood in that context. They go parallelly. The emotional dysregulation and the social skills, they are interconnected. And a lot of times they don't remember how the behaviors because of this episodic memory. I have a lot of different, I'll not go into detail, but that is one of the reasons for it.
I would like to say something.
Yes, please.
From my understanding, all of these social problems as well as emotional problems, they all stem from executive dysfunction only, because in the moment we're not really paying attention to what's happening. So how do we really encode it in our brain that that happened, so I should remember it, because in that moment we're not paying attention. So acceptance, even self-acceptance, really goes a long way in getting over it, because guilt is not really productive, and we can just keep reinforcing what happened.
Yeah. Some of them have sensory dysfunction. So when we talk about poor balance, they're accident prone, and say they're coming from sensory dysfunction, especially tactile and vestibular and proprioception issues. Gets distracted by sound or the clock. Like, I'm working and I was suddenly that, the noise of the tick tick of a second's hand or a fan going, this thing. It can be very, very distracted or very, very bothering. Not because of their inattentive, but maybe because they are hypersensitive to the sound itself. So what I'm trying to tell you is that it's a complex characteristics when we talk about ADHD. It is not only inattention, hyperactive or impulsivity, the way we label or we use the term loosely. But when we understand in the context, in a much more holistic perspective, each of these symptoms needs to be understood why. Then only we will be able to know how to manage it. So the inattention, like आवाज वहां से आई, why did you get up? Why can't you complete your writing? It's not because of their child is inattentive. Maybe the child is sensitive to the sound. That's why he is not able to concentrate. If the sound is sensitivity, sound is addressed. Obviously, that is a different from different perspective. If it is addressed, he may or may not be that inattentive that you thought it to be. So it may not be more of an inattentive symptoms, but more of coming from the sensory perspective. How does ADHD in adult manifests? At work, you might be very focused on the project that I have to do and everything and all that. Again, that notification coming tuck, tuck, tuck for the every email that you get. And then you said, let me look at the mail. And you got involved with the mail that I have to respond on these. And I lost track of the project work that I had to do. Obviously, it remains incomplete. And then you say you can't meet your deadlines, you're lazy and all those adjectives pop up. Hobbies, start but not finished. Maybe I'm good at jack of all trades, I don't want to be master of one. You can look at it different way. Daily life, day-to-day, yes?
I have a thing here. Because we don't jump to conclusions on this because children, when they are young, I want your perspective on it. When they're young, they start out with Bharatanatyam, they don't like it, then they move to another dance form and they want to shift instruments or something. So I suppose that's normal, right? Contextual. Yeah.
That's why I said as a child you would be exposed to a lot of activities and then they realize this is what I like and this is what I don't like. Even if you, after a little while exposure, say in the adolescent period, everything, you might want to experiment various things that I've understood experiment, but I don't want to gain more efficiency in that particular hobby. So from that perspective that I said, maybe some people prefer to be jack of all trades and master of one, not. It's maybe you can look at that perspective. But yes, but the other side of it means that I might be good at multitasking. I can do, yes.
Can we not take it as a master of all? Rather, can we just take it as a sense of exploration, right?
Yeah, that's why I said you might like to explore and gain up to a point certain things, and I don't want to take it further. So my attention shifts from one hobby to other, up to a level. Say I've done the basic level or basic understanding, and I want to move on to the other one. So, but that is a trait level that we can see. As I said, it's not a negative or positive. That's why I said that this is the behavior pattern. You might see it in adult. Do not put a connotation of negative or positive.
No, so can I put it from two premises? First premise, there are infinite things to try in life, right? Irrespective of you try it or not, right? And second premise is, it's likely that I'm not going to like a majority of them, right?
Yeah,
so from 1 and 2, that statement follows, right? Not necessarily it has to be linked to ADHD, right?
Yeah, that's what I said. It is at the trait level that we're looking at it is. It's not that as a person I might like to be certain way, but what is that ADHD trait that we are talking about as well? Because ADHD is a symptom. Beyond the symptom, we are also people. We have other cluster of traits. Right? So some people might be excelling in a way that you want to some people might be want that I want a plethora of this thing. I like to be busy in multiple few things. And say even if I'm a leisure activities, today I want to do A, next day tomorrow I want to do activity B, third day I want to do C. So that way it doesn't have to be judged in a positive or the negative way.
And just related thing, not necessarily about work, but could number of tabs on the browser be somewhat related to that? I'm sure we all have hundreds of tabs open right now.
Let me put it in the audience, what do you think? I think a lot of people will do that, whether we have 4 or a 10, that's a matter of choice, but yes.
4 is very low. Hundreds we are talking.
I have about 60.
So while we talk about ADHD, when we talk about ADHD in adults, we have to look beyond the core symptoms of inattention, hyperactivity and impulsivity, because we don't see that much in fidgetiness or impulsivity in that nature. Maybe more of a verbal impulsivity than physical impulsivity. So the manifestation of these things keep changing. And some things it moves into, whether it's not a question of good or bad, because when we talk about trait level, it is more for us to understand who we are. I might be an anxious person, doesn't mean that I'm a good or bad. In such a situation, anxiety might be good for me. To perform in a task, for an example, I probably need a certain level of anxiety for optimal performance. Over is not give me the good results, under it will not give me the good results. So certain level of anxiety is probably needed. If I'm an anxious person, I have to know whether it's not I'm a good or a bad. If I'm a risk taker, right? It is not good or bad. In such a situation, the risk taking behavior is detrimental. Risk taking is what? Experimenting, right? In such a situation, probably it is needed to succeed. For example, if I'm experimenting, when we talk about, say in the context of ADHD, we said experimenting, we want to try novel, right, a task and everything. We might want, that is one is a good thing that we want to experiment, right? At a certain age, with certain things, experimenting, we can get into that. As I said, the first myth, if I say it is an inherent condition in the ADHD, substance use. Remember? The first slide that I talked about? If I experiment, I can experiment with drugs, it can lead me to this thing. But if I want to be a good surgeon or a CEO, I need to have that risk-taking behavior.
Like you said,
so it's not that's what I said. In adulthood, when we look into these things, it has to be in that context, good or bad. Yes, please, what were you talking about?
So like you said in the very starting, problem can be turned into strength by management and career choices.
Exactly. So, in that myth, again I will bring it back when we talk about the treatment, when we talked about parenting. So what I'm talking about is when we go talking about adulthood, we are going beyond the symptoms. We are looking into the executive functions. That is how it manifests in adulthood. अगर उतना hyperactivity तो वो तभी diagnose हो जाती है. If you fell off the system or you did not go diagnosis, that means you are looking at the different aspects of the or the associated aspect characteristics of the ADHD in there. And you are looking at the people have why you are experimenting and why you are trying out multiple things, multitasking or multiple things. Because you have a low threshold for boredom. Now, low threshold for boredom is bad in a sense unless we train ourselves to do that. Children with ADHD or individuals with ADHD, they have IQ level normal to higher level. Average to above average, right? Low threshold for boredom. If I look into the context of a child, I understand the maths concept. I do not want to practice it, but I have to train this thing that if you want that marks, I need to practice that. Understand the concept, will not get it. So that is coming at the behavioral management. That is what you're looking at to practice up to a level to do that. But the inherent nature, if you look it into those continuum, say 1 to 10, with practice low threshold for boredom, if you have it 2, we can shift it to 5 or 4. We cannot make it to 8. That's the difference what you're looking for. But even do that, the low threshold for boredom is actually providing a basis or a platform to try out new things, which is the other aspect of what you're talking about, to experimenting or to, which in certain situation is actually taking that risk. So that risk in adolescent, if you're looking into the thing with that unguided this thing, you can go into the drug abuse or dependence. The same behavior, you're looking to take the risk to be at the top of certain professions if you want it. That's what I'm talking about here. Sleep, they do have issues. A lot of us we do now, so it's little difficult to say that it's basically if you don't really conscious of sleep pattern or the timing, it's easier to get haywire because you might get doing certain things and losing track of time. We've already said in the first slide of the make that it's in biological factors. As I said, retrospective studies tells us prefrontal cortex, cerebral volume, with certain brain functions, neurological circuitry, they are affected. That we know that there is a difference between individuals diagnosed with ADHD as compared to individuals who are not diagnosed with ADHD. But again, to reiterate that it is retrospective studies that we know there is a biological cause. The cause of the ADHD is biological. It is not so much of environmental, but yes, certain environmental factors like toxins and everything does play impacts. Like if there is any during the birth, if there is any trauma, like which is not specific to ADHD, but multiple developmental disabilities. Our children with different kinds of development disabilities can be at risk for certain other factors, psychosocial factors around it, like a toxicity or pre, peri or postnatal factors like that. The comorbid conditions that we talk about with ADHD, which is common, as I said, learning disability or the disorder that we understand, especially the inattentive part of it. Autism spectrum disorder, I'll not go into much detail, just for your knowledge that these are the other, comes with very high comorbid rates, anywhere between 20 to 60-70%. When we talk about emotional dysregulation, leads into the depression or bipolar disorder, the mood disorders. Behavioral level, if it is not managed well, it can lead to oppositional defined disorders and the conduct disorders. These are very high comorbidity if at an early age the children with ADHD, because of inherent, which can, as I said, these are the aspects. Let's look into the both sides of the coin, the positive and the negative. If it is not, then these are the other high comorbidity. When beyond a level, if it is mismanaged, the symptoms at a behavioral level, then these are the high risk of associated mental health conditions that can develop. Now the treatment includes pharmacological treatment. In this context, medicine is a first line of treatment, but above the age of 6 years. Below that, first we try with parent management and behavioral management. Efficacy of medication is not so much. So what we say is that when the child starts formal schooling and during the classroom situation, if they are becoming more disruptive, then you can consider medication with consultation with the psychiatrist. Yes, please.
Sorry, I had a question on the previous slide.
Previous one. This one?
Is the onset of the comorbidity, is the onset for that the same for adults as for children?
Onset of which comorbidity?
So all these comorbidities?
Not necessarily, because autism and learning disorders are diagnosed at a young age. Substance use, bipolar, all of this can be done at an adolescent. Early diagnosis is adolescent. Mostly. ODD, opposition defined. Yes, we can do it at the late childhood, primary schooling.
Also for
So not all of them. It has to be for adult.
Okay.
Adult also, but most of them are, because ADHD by itself is a childhood diagnosis. When we do it for adult, we have to look a lot of things in retrospectively. It's not an adult diagnosis as such. As I was talking about the pharmacological intervention, the medicine part of it, if you feel that the child is not able to do the regular activities in school and it is becoming disruptive, take an informed choice. Do not get scared that there is a negative impact or side effects of a medication. Discuss it with your doctor. The psychiatrist is the right person to do that. Any psychiatrist would give you that information. What all I want you to highlight here is take an informed choice, understand all the side effects, understand the benefits, and then take a call. The final decisions rest with you as parent or as an individual, but take an informed decision. That's all I want to say in the context of the pharmacological treatment. Psychosocial treatment, these are the common ones, but as a general people, the thing can be done, I would like to highlight on these aspects of the psychosocial treatment. Parent-child mostly involves, to answer your question coming to here, when we say, the first slide, if you remember, when we talked about the myth, and I said I'll revisit this question, it's if the cause is bad parenting, cause is not a bad parenting, but bad parent, or rather mismanage or not able to manage properly, can lead to difficulties. And how to manage properly from an early age, these are some of the things which you can consider. All of them are not very specific to ADHD, but most of them are. Allow open communication without judgment. Establish clear expectation which is realistic. First of all, you need to recognize what are the triggers. When we talked about emotional dysregulation, if you remember, we said the meltdowns, anger outbursts. We need to understand, and we talked about inattention, why it could be. Is it inattention? Is it sensory dysfunction? The meltdown, is it because of, you had a breakdown with your friend, you could not sustain the friendship that you initiated it? It could be the thing. So you need to first find out what are the triggers. It could be stress because you could not organize yourself properly for a project or something. Rejection, you lost friendship, organization, social conflict, sensory overload. You need to first identify the triggers. Once you are able to understand the triggers, then we need to deal with step by step how to do it. Establish what we talk about parent scaffolding and use of declarative language. What does it mean? I understand today you have a bad day. What a smart kid you are, you got it. It's a very generic phrase. If you be specific, I can see that you've been patient today. You handled it with patience. You did not lose your temper even though you were provoked. So you're sticking to the behavior. So that is what the examples of declarative language it means. So what you're giving in this specific. So when they have a meltdown, I can't do it or anything. You remember what we talked about just now, episodic memory. That you remember the way you handled that friend, fighting with your friend. So you're recalling the positive thing that you've done with the thing. So these are the sum which is basically builds over a period of time. So in the context of that, I'll not go into some of the examples. That is what it is. Validate their emotion and support their emotion. When we know that they have more emotional dysregulation, that is not the time that we say, why did you do it or you do it or lecture, no 20 questions, no advice. Wait, support, validate that. I can understand you're feeling very angry right now. Support it, will support, give it in. You will have that time to tell what to do and what not to do later on. So supporting, validating their emotions and support emotions at that point of time. Give time, relaxation time, free play. When we say sensory overload or when we say they're stressed out, when you're disciplining them, you have to do this boring work. You have to give them free time to release their energy. Okay, now you free time, do whatever. That is not the time to discipline or anything. So you have to understand what to do and when to do, what to do and what not to do. That is basically what you're looking for. So over a period of time, they learn these skills, especially the executive function skills of emotional regulation and cognitive flexibility in the context of inattention and impulsivity. Tap into the episodic memory. I just gave you those examples. Clear expectation. I expect you to do this. Over a period of time, this is part of the disciplining that you learn. They might take it a little bit longer. They need more structure and support as compared to other kids, because some of these are common, that it's part of discipline. The difference between other kids and children with ADHDs, they require more structure, they require more remembrance or more practice to develop these skills over a period of time. So what can be an inattentive can be converted into a strength.
So
Yes,
may I
please.
share if you don't mind?
Yes.
What I used to work with was I would, not expect him to study for too long. So let's say half an hour when he was younger, and then of course in grade 11 and 12, it had to go up to an hour. And then I would let him take 10 minutes breaks. And then, everybody was like, other people's children would be studying 3-4 hours consistently, not mine. He would study for, X amount of time and then take a break. The other thing that worked very effectively for us was that I'd put up a timetable, print out a daily timetable, stick it up on the cupboard or board or wherever where he could see it, and everything was written down there. So, he could manage, 11 baje tuition hai, 12 o'clock, whatever he has to do, things like that. That made things a lot more structured and a lot easier. And the third thing that worked really well for us was that I encouraged him to go into a sport. So he was swimming, and swimming helped him a lot because, there's a very mechanical thing of going up and down, and you also kind of meditating because you're focusing, and your body calms down, slows down, and it gives you that relaxation sort of a thing. So these were the three things that worked. But I
They have higher energy level. Getting into the sports is a very good thing.
I would really like to understand from you in future how to.
Any more questions or anything on this?
Just a comment, I think.
Yes, please.
I'm not a parent yet, but I think my mother treated well about episodic memory and declarative language. I remember now, I can connect that she used to say, okay, you did well this time. You remember 2 years ago this happened,
and it's not the first time it is happening to you. So events like that, I think she did well. I'm gonna use it for my kids.
Hi, Shruti. This is going.
So can I ask a question, please?
Yes, please.
In your earlier slides, you had said when you were defining ADHD, that's the first slide, you used inattention and hyperactivity. So is it always an and?
No, it could be ADD. You can have inattentiveness without the hyperactivity and impulsivity. When we say ADHD, that includes both. You can have a mixed type with both inattentive, being inattentive as well as hyperactive and impulsivity, or you can have just inattentive type without the hyperactivity and impulsivity, which is called ADD. Yes, please.
I have a question. You gave us one sentence of emotional dysregulation and stuff.
Yeah.
Of emotional dysregulation. So how many would be, a child would have all of them?
Yeah, definitely.
So then, like how many? At least 5 of them or 7?
There is no rule that 5 or 6 like that. It depends on, also the emotional dysregulation. That's a very abstract term. What you're looking into, the behavior, how it is manifesting. Meltdowns if it is too many. Because as I said, you have to look into the normative. A child of 2 years is supposed to throw tantrum. Because they do not, if they're upset or something, they cannot express it verbally. Even a child of 4-year or 5-year-old, when you're emotionally heightened, you cannot say, "Mommy, I'm angry," right? You will throw tantrum. Your first reaction is behavioral, reactive in a behavioral way, throw, hands and fists and push or something, right? So everything has to be in the context of it. When we say ADHD or any of the symptoms we're discussing, We are looking at when each of these symptoms are off balance, in the sense, if it is affects daily life regularly, at a personal level, social level, interpersonal level, education or work level, is disruptive or it is impacting, which you are not able to handle it, right? After once you have done, say for example, if I take an example of a 5-year-old, if you're throwing a tantrum on a 4-year-old, you would first try it at a disciplined and behavioral level like any other child. Before we say the child is emotionally dysregulated, for example. Once you have tried the discipline issues or behavioral, and you are saying that it is not working, right? It's like, for example, in any medical conditions, we do the first, kind of understand it is when it is going beyond that threshold. And then you need to figure it out whether, and you need to consult a professional that is it beyond the threshold, what I am thinking, and get it confirmed. So at a certain age, again when I talked about inattention, even this emotional disorder, because there you're learning the child is, even an adolescent for that matter, their prefrontal cortex is not developed. What we know now is a functional aspect of the brain continues to develop from 20 to 24 years of age. That means an adolescent of a 9th grader or 12th grader would throw a tantrum, they are depending on the amygdala part of the emotional part of the brain. So they are emotionally more volatile. So when you are looking at that, this is beyond a level. I'll not go into the details because other aspect is there. So what we're looking into these symptoms here always in the context of, and in general, any mental health condition, what you're looking for, whether it's ADHD or depression or anxiety, what you're looking for, if it is impacts your day-to-day life or different multiple domains of your day-to-day life, as I said, personal, social, interpersonal, work, education, everything, and you're not able to manage it, that's the time that you're probably crossing the threshold and you need to consult at least a professional to tell you whether you're right or you need to do anything about it. That's about it.
Thank you so much.
Yes, please.
So we talk about the need to have more structure to remind these children again and again of their schedules, what they need to do. But how does one deal then with the emotional outburst bit? It seems to be a cycle of sorts.
Not necessarily. Say for example, if you throw a tantrum, you can tell the child that when you're getting upset or anything, this is what you do when the child is calm. When a 4 or a 5-year-old is throwing a tantrum, you would let them to do the reason. As I said, first you need to understand the triggers. Lot of times if it is a sensory overload, it needs to be handled differently than it is a temper tantrum. So these has to be done, understand, it has to be child specific. What is what, and that comes little bit with practice when you're working with a child and in consultation what we basically take up understanding, because every behavior is not because of ADHD. So we need to understand what is normative behavior of the age appropriate level. As I just said, adolescent, emotional outburst is common, but that is coming from a different angle than a person with ADHD. So it's a degree and how it is, that is how it needs to be addressed and managed.
But for example, if you see somebody consistently trying to follow a schedule, trying to do their tasks, but they can't, as a parent you would try and remind them. But that in turn might lead to an emotional outburst because you are doing it constantly. So how does one balance
so then
that?
first you need to know, understand, see, as I said, first you tried it, that you're not able to follow the schedule and everything. And it is it is disrupting your, kind of say educational things and everything, then that is the time you need to consult. That whether it is coming into the ADHD spectrum or not, or whether it needs to be dealt only at the behavioral level, or is just a normative level. So that has to be consulted. As I said, beyond once you crossing the threshold or you managed it and you're not able to do it. Say for example, if you're having a fever, when you have a 99 or 100 fever, you don't consult a doctor, do we? None of us do. When we persistently say, no, it's like 100 it ho gaya, it recovered, again it's coming, or it is crossing 100, crocin is not helping or anything, then we say, let me figure out, probably it is not simple viral, maybe it is something else. So that first level of behavioral management, we do it anyway by default. Yes, please.
This was just in relation to what ma'am said about if routines work for everyone. I actually do have a friend who has ADHD dealt with it really well, that was. Actually, her parents did try to work with the routine way that you were talking about. That even with breaks, for her it actually got worse. Till the time the parents actually got some professional to help, and the professional said, okay, let the child be involved in the routine making process. Let the child sit with you and be like, okay, this is how my day should look like. And that's when it actually got better, because she used to later on tell me that, okay, how that actually built accountability for her. And it wasn't just her being like, okay, I need to follow a cut-to-cut routine. So I think even when the child...
That's an example of open communication, especially with adolescents or older children. If they're part of it, they think they will become more responsible for it. So that's another topic altogether. If you talk about the parent communication skills and all that, but some examples are there. So that is how you understand it. So coming, if I round it up to this thing, so we have to looking into the two sides of the same coin. What you're looking into: inattentive, hyperactive, impulsivity, low threshold for boredom, lack of emotional control, social skills deficits, sensory dysfunctions. This is what we talked about. The other aspects of it, some of it is not specific to ADHD, but these do get heightened if you are able to manage those symptoms. Hyperfocus, creative, they are generally, if you are bored, low threshold for boredom, you will be experimenting by default anyway. Resilient, and by the time you heard so many times the scolding and everything, you will develop the coping skill by default anyway. Enthusiastic, because if you are impulsive, you think, you act first, think later. The other side is that you're open to more enthusiastic about everything. You say yes before you say no. An anxious person's first reaction is no. For a person with ADHD trait, they will say yes, I will not to try, I'm open to everything. Because that's the other side. I've not thought through it, but first idea is, it sounds great to me. You know, the other extreme of being overcautious. Risk taker, getting out of comfort zone, I just use that. If you're not thinking through impulsive, this is the other side of the coin, multitasking. So when we look at it, if we learn how to manage it, maybe we have a lot of strength. We do not have to look at it. I just wanted to what I wanted to give is this thing, take a balanced perspective, understand the context, the symptoms in the context, especially the developmental context, and don't use the terms so frequently and so casually, please.
This treatment,
Yes, please.
how much is the success rate? And the second question is regarding these psychological nitty-gritties which you are told for the last 40-50 minutes. In the cities only these things are available. 70% of India lives in villages. So have you outreach program there? Because many people living there, they either accept this as a part and parcel. Otherwise, they say as the child grows, it will get, and some it happens. It gets order. It gets into order. Otherwise, they take it as the life passes.
See, what I can say only is that at VIMHANS, we have the full spectrum of socio-economic demographic of patients coming to us. From pre-patients, below poverty line, to very high-end patients. So, the specific that we talked about, I give you an overview. When we deal with children with ADHD or adult, we moderate it, depends on, these are the overall, the broad umbrella terms. It has to be given in the context what is possible and not, depending on the situation what is coming from. Other than what you're talking about, that yes, it is available only in the metro cities or the big cities or tier 1, tier 2 cities and not beyond that. That is not specific to mental health or ADHD issues. That is across the board for any medical condition, any health facilities, or for that matter, any facilities if you talk about even the basic necessities. It is now filtering it out, so far it wasn't. So that answer I can't give you whether it is in village, whether it is possible or not, but if they don't have enough fresh water to drink and all that, there's all the basic health amenities, we are not talking about mental health conditions there. So it's not specific to ADHD or mental health conditions. That's a public health perspective that you're asking with the question. Other than that, in the cities, even if it's a patient who is coming from a free patient from a below poverty line or from a high-end patient, we structured it accordingly, what is possible within keeping in the context, what is the risk factors that we are dealing with specific to that family, what is the maintaining family factors that we cannot change, and what is the protective family factors that we do have within that family, which can be used to improve the conditions when they are seeking the help with.
The cost factor is also involved, and in the cities.
As I said, we do deal with we have a free patient that is across. It's a private hospital, so we do have our percentage of the free patients that we deal with, and so that is not the context of this context. But to answer that, so in VIMHANS we do have the full spectrum of the patients that we deal with, and from the treatment perspective, that all we can say, it is individually tailored. That is what the idea of one individual therapies means, that it needs to be individually tailored, whether it's ADHD or depression or anxiety, and it is done in the context of there is a format and there is a process. We understand the family's concept of risk factors, maintaining factors and the protective factors, and that is how the therapies are structured, and short-term and long-term goals are set.
The last part is the success rate.
I don't have the statistic with me, I'm sorry. If anybody has to it, but I don't have right now success. As I said, success rate, you can say the people who are seeking treatment and who are following through the treatment. There's a lot of factors. I don't have that success rate right now with the statistics, I'm sorry. Any other questions?
I would like to ask what you mean by success.
Yeah.
Because you can't really get rid of it.
It's a lifelong condition. Yes, it's a lifelong conditions. If we manage, we learn how to manage. But then most of the conditions, medical conditions, whether we compare with diabetes and all, these are lifelong conditions. If we manage them, it doesn't disrupt our life. But if we don't manage, even the medication, it does not work if you keep eating sweets once it is diagnosed with diabetes, for example. So let's look at it in that context.